thank you very, very much to all of you for inviting me to spend this evening with you. I'm going to talk a little bit about bringing together mental health and primary care, hopefully with sort of the idea that there is a big gap between what we know how to do and what we actually do in most of our settings, and maybe in the process of bringing those two things better together, we can close that gap a little bit. I'm going to do a little bit of disclosure. So I'm a professor of psychiatry at the University of Washington. So I'm an academic. I'm kind of an egghead. I spend my time studying things in this area. I have grant funding from federal funders and foundation funders. I have a contract with a health plan in our state that is essentially owned and operated by a large network of community health centers. I do some consulting. I don't do any work for device or pharmaceutical manufacturers. So if you detect biases, they don't need my help, I don't think. They got all the help they need. I direct a center at the University of Washington called the AIMS Center, and that stands for Advancing Integrated Mental Health Solutions. And it's a group of us that have a passion to think about what does mental health care look like in places that aren't specialty mental health care settings. But it's a pretty big range that is primary care settings. We do work with school-based health centers. We do work with senior centers, essentially pretty much any place where, it's not a designated specialty mental health care setting. And there is a reason for that. We're up there in Seattle, Washington, in the Pacific Northwest. We are the only medical school for a 5-state region that covers a quarter of the landmass of the continental United States. So it's a huge region. And we do pretty much most of the sort of professional level workforce, health workforce development there. We have a big psychiatry training program. We have 65 psychiatry residents, and if we tripled that program and graduated 3 times as many psychiatrists as we do in a typical year, we would still have a number of counties in the Pacific Northwest that don't have a single practicing psychiatrist in 15 or 20 years. So that's not a solution. So in some ways, we are looked to. We have a big department. We have 200 full-time faculty psychiatrists in our department. So we're looked to see what can we do to try to help leverage that expertise and help our colleagues in primary care. So I did my training, and I spent a long time on the faculty at UCLA. So I used to live in Southern California, and the environment there was very different. We had 5 medical schools and lots of specialists, and what attracted me to the Pacific Northwest was this issue of there's a real need for these kinds of solutions. I brought with me a colleague of mine, Anna Ratzlaff, who is on this picture also. She's one of our psychiatrists, one of our junior faculty. She does this work, and the project I'll describe tonight, she's one of our consulting psychiatrists, and one of the reasons she came down with me is she grew up around here, a couple miles from here, and she's been a wonderful tour guide for me today. This is a really, really gorgeous place. So, all right, see if I can handle this technology, make sure that nice man doesn't come back. All right, so what I'm going to do, I'm going to talk a little bit about why do we try to do this integrated care thing, why are we doing it now? I'm going to talk a little bit about research, but not so much, and then I'll try to tell a story about a program that we have in our state called the Washington State Mental Health Integration Program. And I think I've talked to a number of you before this presentation tonight, and I think in many ways we are all facing very similar kinds of challenges. And hopefully there are some useful ideas and lessons from this program that we started in 2008 that might be useful in some of what you're taking on. So actually, before I go on, can we just do a quick raise of hands? Who in this room would identify themselves primarily as a mental health or substance abuse provider? Okay, that's good. All right, that's great. How about primary care providers? Ooh, that's just about half-half. That's very cool. How about other? All right. Okay, very good. That's actually beautiful. I'm going to speak mostly now to those of you who are in the mental health substance abuse business, because the primary care providers, they know this stuff. So why are we doing it in primary care? Three things I'm going to try to point out. One of them is it's just a matter of access. And just as I mentioned earlier, there aren't ever going to be enough mental health specialists to meet all the needs that we have in this area. It's very practical. So we want to go and figure out, can we serve the patients where they are? So there really isn't a wrong door. The second one is this notion of patient-centered care, the notion of treating the whole patient. I'll say a little bit more about that. And then the third one, and this is when I'll talk a little bit about research, we actually would like to do care that gets our patients better. We do a lot of care now that actually doesn't get our patients very much better in mental health care. I hate to say this, it's true. I'm a psychiatrist, and I'm involved in that. But when you look at it carefully, there are a lot of things that are really well intended, but they're not getting that many people better. This is about access. So this is a slide, and I'm not going to show a ton of data, but I'll show you a little bit of data. From Phil Wang, who's the Deputy Director of the National Institute of Mental Health. He did a really nice study, a national comorbidity survey, where they went into households all over the country, and they identified people who met diagnostic criteria for mental health disorders. Lots of them, over 10,000. And then they said, in the last year, have you had any kind of services for a mental health or substance abuse problem? And this is what they found. 59%, no service whatsoever, nothing. 41% said, yes, I had some help. And if you look at where they got that help, 56% in a general medical setting. So that's primary care. Okay, hey. And then 44% of the 41% said, I saw a mental health professional. Now, how was that defined? If you had even one visit with a licensed clinical social worker, with a pastoral counselor, with a marriage and family counselor, you were counted in this box down here, one visit, right? I think my pointer just died, so I guess I won't be doing a lot of pointing. That's good. No worries. Oh, you guys are great. That is beautiful. Now I got two things to juggle. All right. So then you were down here, but look at this. Most people got nothing. 40% got something, and most of where they got it is in general medical settings. So I was challenged by this. And I said, we're in a large academic healthcare system in Seattle. We have a couple of hospitals, and we have a whole bunch of clinics, and we have 200 psychiatrists. So I looked at 2009 billing data out of the University of Washington healthcare system, and I looked at all the bills that went out the door where the claims diagnosis was a mental health disorder. And I first looked at all the ones that we did in psychiatry, and then I looked at all the ones done in primary care. And for every one of those that we did in psychiatry, there were 4 done by one of our colleagues in primary care. And that's in a very enhanced setting. We have 200 psychiatrists. So it was very clear to me that if we were really going to, on a public health level, want to make an impact on mental disorders, we got to see where people are showing up, which is basically in primary care. But here's the reality. This is the same big study. They asked people, they asked a couple thousand PCPs. They asked a couple thousand PCPs in that same study how they felt with access to specialty care. And the number one complaint was about behavioral health care. 2/3 of the PCPs surveyed said, we have lousy or no access to mental health care. And when we get somebody seen, we never hear anything back. It's like they go into this black box and we don't have very useful communication, and not a general state of happiness, a lot of complaints. So I think you read I could tell you read the quote. Now I'm going to switch gears a little bit and talk about this notion of patient-centered care. So I'm a psychiatrist, and I see, like many mental health providers, I see everything through the lens of mental health and substance abuse. Anything that comes in front of me, that's my lens. That's what I see in people. But the truth is, of course, my patients have diabetes and heart disease and neurological problems and cancer, and many of my patients, and I have grown to realize this much more than when I was first out of training, have what I would sort of consider a really wicked mixture of emotional pain from a mental health and substance abuse problem and chronic physical pain. And that's a really, really wicked combination to try to treat. And it's not anybody that owns that. There isn't a specialty that really is after that. And then, we've got a whole bunch of unhealthy behaviors. So If I just look at the patient with this lens, I'm missing so much. So if we really want to do patient-centered care, I think we have to. This is my number one, on an individual patient level, this is my number one argument why we can't do it all siloed out. And I have this little picture down here. This is a chicken and an egg. And I put that there because my specialty is I'm a consult psychiatrist. I love the challenge of teasing out what's the medical, what's the mental, how do these things drive each other. And you know what? I've done this for a long time now, and I'm not very good at it. It's very, very complicated, right? Because it's just complicated. You know, and another way to say this is these things really drive each other. So we know, and we have learned now, that our really severely mentally ill patients, so our schizophrenics, our really sick bipolar patients, they're dying 25 years earlier than non-mentally ill patients. And if you look at what they're dying from, they're not dying because they're making a suicide attempt, jumping off the Golden Gate Bridge. They're dying because they're having strokes in their late 40s and early 50s, where most of us hopefully are going to have our strokes when we're in our 70s and 80s. You know, they're dying from untreated hypertension and untreated diabetes, and it's not super complicated stuff that they're dying from. But they're getting their care in a mental health center where the psychiatrist is the only medical professional in that mental health center, and they haven't prescribed anything, you know, but a throat lozenge since they've been a year out of their medical internship, right? They're prescribing the most wicked combinations of psychotropic medications, but they won't prescribe an antihypertensive. So we've got it very well siloed out. And then the reverse is true too. So if you have say diabetes and you develop a serious depression, it's going to knock down your medication adherence. You're not going to be as successful in stopping smoking, in losing weight, in exercising. And you have a significantly higher mortality. So these things are just, you can't disconnect them. They really, really do drive each other. And also, if you're a depressed diabetic, your healthcare costs are going to be 50 to 100% higher than if you're not depressed. So this is how we take care of people. I grew up on a small farm, so I like agricultural metaphors. These are silos. I don't think a lot of silos around here. We're not in the Midwest. Our Secretary of Health in our state, when I showed this slide at a meeting recently, said, these are not silos. In my shop, these are called cylinders of excellence. I don't know how, I was blown away. I thought that's really beautiful. I love it. So we got these cylinders of excellence. You probably have some of them too. So we have primary care. We have community mental health centers. We have alcohol and substance abuse treatment facilities. We have social services. I couldn't put enough cylinders, so I put the vocational rehab services in the same cylinder, but they're not often in the same cylinder. We have other kinds of community-based social services, and all patients have access to all of this. And a couple years ago, I was asked to see a client who had been seen in all of these. I asked him questions about depression and anxiety, and he said, look, he said, this is funny game, he said. You know, this is about the 6th or 7th time I'm being asked these questions. You know, I went to a primary care center, I went to another one, an FQHC, they asked me about that, and I went to an alcohol program, they asked me those same questions, about 70% the same questions, he said. I went to vocational rehab, and they said the first thing we can do before we can do anything else for you, you've got to have an intake with a psychologist. And that person asked me the same questions. And now I'm here with you, you're asking me these questions, and don't you guys talk to each other? And I said, well, of course we don't talk to each other. And then he asked me a much harder question. He said, and when does the treatment start? Because he said, this is kind of the same game everywhere. He said, it's called an intake, and then you know, some of you are faster at it than others, but it's pretty much always the same thing, and I haven't seen a lot of treatment yet. And I thought about this, and it really challenged me, because I thought, we have spent a lot of money on this man. Every one of those intakes is a couple $100. You know, it pays all of our mortgages, so that's nice, but it's not helping this man very much. So I think it's really a challenge to try to sort of do a little bit better than this. And this is what we do. So if you look at the average person who gets identified and treated with a mental health problem in a typical community health center, 25% really not really effectively recognized or effectively engaged in what I would call, you know, a reasonable course of care. 25% are started on something that could help, antidepressant medication, something like that, but they drop out way too early. If they don't come back, you don't know about it. It's out of sight, out of mind. You know, primary care is a really, really busy place, and you know, how would you know? And then there's 25%, and this is kind of a new thing. We start them on treatment, and they take their meds, actually, and they take them for a long, long time. But if you look at them, they're really not much better. So it's only about 25% of people with common mental disorders that actually really are significantly improving. So I think we're missing the boat with a lot of people. And I don't say this in a blaming way, because there is no value in trying to sort of point fingers. It is what it is. And so we have some other limitations. I think we don't coordinate, as that man pointed out to me. And we look to these clients to try to navigate what are really, really complicated things. You know, I've been working now with safety net clinics in Seattle for quite a long time, and I can't figure out how to navigate all this stuff. I don't even know who to invite to all the meetings where we're trying to talk about all this stuff. And I'm thinking that our clients could try to figure this out, right? Pretty challenging. So a little bit on healthcare reform. This is a slide from Washington State, where we are. Actually, we have a fairly small Medicaid population. But we're looking at more than tripling our Medicaid population if Obamacare doesn't go away by 2014. And when we look at those patients who are going to get Medicaid eligible, they're 60, 70, 80% of them have mental health substance abuse needs. And there's no way our currently existing specialty delivery system is going to be able to handle that. So we have to figure out what are we going to do, how are we going to address these needs. These are some of the numbers. So these are the dually eligible in our state. There's two types of duals. There's the older duals and the working age disabled. And what I'm showing you here is claims diagnosis data for mental health claims or psychotropic medication prescriptions with the older duals. And this is just the Medicaid data because I can't get the Medicare data. So this is probably an underestimate, but the older duals, almost 50% have claims or treatment for mental health problems. And the working age duals, you know, it's 2/3. And it's a huge challenge. So if you think about healthcare reform, this is a kind of a beautiful slide that I got from Paul McGann, who's the acting medical director at CMS. And that's kind of their vision. I don't think you can see it very well the way it looks here. So we're trying to move from what is essentially an unmanaged fee-for-service system where everybody is in their silo billing for a billable widget of one type or another to something that's more coordinated and accountable to hopefully actually something that is really truly patient-centered and integrated. And we're thinking about how to build patient-centered medical homes and accountable care organizations, and how do we make better use of health IT. And I think in that context, there are some really, really nice opportunities and roles for behavioral health providers. And I think it's a very important time for those of us who are in behavioral health to look at this stuff and say, how do we fit in here? How do we add value here? I think it's our opportunity to come out of the silo and to try to really add value. There are a lot of ways to bring together mental health and primary care. There's different approaches that have been used in different settings. I'm going to review one flavor of integration called collaborative care, and I'll give you a couple of examples of such programs. And although they vary a little bit, I think there are some core principles that you can pretty much hang your hat on, and I'll try to go over those principles in just a little bit. Before I do that, I'll talk a little bit about research evidence. So there are a whole bunch of studies that have said, how do we do this? There are actually over 40 randomized controlled trials. So these are the big experiments where patients get randomly assigned to a new model of care or another model of care. And people have done 40 of these for depressed patients in primary care. And they've been done in the United States, they've been done in the UK, they've been done in Holland. And there's a beautiful meta-analysis for those of you who like to read those kinds of things. Simon Gilbody is a British researcher. He published in the Archives of Internal Medicine in 2006 a meta-analysis that looks at these 40 trials. And basically the message is very strong. Well-integrated collaborative care in which you have a primary care provider collaborating closely with a mental health provider is going to beat the socks off a more traditional system where everybody does their thing in a silo every time. It's a very, very strong evidence-based. There are now more recently similar studies that have been done for anxiety disorders. There's a big study done, actually a couple of California sites in that study, the CALM study, and then a colleague of mine up in Seattle has done really, really nice work with PTSD patients, not just military type PTSD, but people who come into our county hospital trauma center. And when you're in a bad car wreck, half of those folks have serious alcohol and substance abuse problems, and it's a powerful, teachable moment. And if you can engage those people right there in the trauma center and say, we need to do something other than sewing you back up, because otherwise you're going to be back in 6 months and we'll sew you up again, you can actually do some really, really nice work, even in that kind of a setting. I'm going to talk a little bit about one condition called depression. I think if it kind of as an indicator condition, it's a good example. It's very common. 10% of the people who sit in the average primary care doctor's waiting room on any given day meet diagnostic criteria for major depression. This has become one of the most common things you see in primary care. It's the #2 cause of disability according to the World Health Organization, right after heart disease. It's very expensive. As I said already, if you develop today a major depressive disorder, if you go 2 or 3 years out from that, you'll have increased your total healthcare costs 50 or 100%. And the sad thing is that increase is not coming from better mental health services. That increase is coming from you're miserable and you're going to the doctor a lot and you're going to the ER a lot and you're having higher inpatient costs. And if you're an inpatient, you don't make it out so fast. It's very complicated. And it's also a deadly problem. There are more than 36,000 people in this country that commit suicide every year. And I would say depression is behind most, not all, but most of those cases. I'm going to talk now about one of those 40 studies. It's the largest one. It's a study that I had the pleasure of coordinating when I was at UCLA almost 10 years ago now. The IMPACT study, we had funding for this from the Hartford Foundation and actually the California Healthcare Foundation. I think there's a number of you here in the room who are doing work with the California Healthcare Foundation. They had the foresight 10 years ago to give us money to try this. They thought it was pretty wacky, but we gave it a good try. So we took 1,800 depressed adults from 18 primary care clinics in 8 healthcare organizations. So our organization would be a medical group in 5 states. They were really diverse. We had urban settings, we had rural settings. About half of those patients were in capitated care, half of them were in fee-for-service care, and they were referred to us by 450 primary care providers. And what did we do with them? We took those patients, and half of them got assigned, randomly assigned, to what we call usual care. And that basically was what it was, what it says. So we said to those patients, look at that, it came back. You're going to work with your primary care provider, and your primary care provider is going to do whatever he or she can to treat your depression. Or you might get referred to a mental health specialist. And 70% of the time, a PCP pulled out a prescription pad and wrote a prescription for an antidepressant medication. And 25% of the time, they were referred to a mental health specialist. So this is not a placebo group. This was kind of an enhanced usual care group because we diagnosed all these people and we said to the patient and the doctor, you've got depression, do what you can do to fix that, and we're going to follow you for a year. And the other patients, we took the same patients, well, the other half of the patients, and we put them into a collaborative care program that I'll talk a little bit more about, and we offered that to the patient for 12 months. And then we independently assessed all those patients. It comes and goes. 24 months we followed them, and we did that blind to knowing if they were in the usual care group or in the control group. We had researchers assess those patients every 6 months to see how are they doing. This is the model. So we said, we've got these 18 primary care clinics, and we got a primary care provider who starts treatment for depression. And in every one of those offices, we trained a professional, we call a depression care manager. Those were nurses, we trained psychologists, we have trained licensed clinical social workers, and in one of the organizations we work with, they split the role between a nurse and an MA. And we said, what is the job of that person? The job of that person is to help this PCP keep track of a caseload of depressed patients in their practice. We taught these care managers how to do brief education about what is depression, how does it affect you, what you can do to help yourself. We taught them some brief counseling skills. We taught them a 6-session method of psychotherapy called problem-solving treatment that they could provide right there in the primary care doctor's office, so we didn't have to refer the patient out for that. We also taught them how to help a patient adhere to medications and how to spot when a medication was not working. This was a huge part of what we taught them. And they often said early on, well, I'm a social worker, I can't talk about the meds. And we said, that's not good enough because the doctor only sees you 3 or 4 times. You see that patient a lot more. So every time, if they're going to take a med, you're going to say, what are you taking? How are you taking it? Is it getting the job done? You don't have to change the dose. You don't have to prescribe it, but you got to ask about it. And what that created is tons and tons of opportunities for them to say, he is taking the med, but I don't think he's any better. Let's make a change. And that was very, very important. We also, these are a little bright, so I can't. Every time we saw one of those patients, we did a PHQ-9. Who here knows what a PHQ-9 is? About half of you. That's great. So a simple 9-item rating scale where the patient checks off how bad their depression symptoms are. Very easy to use. And we said this is really, really important because I spend a lot of time working alongside primary care providers, and one of the days I was there, it dawned me that one of the things that they do, they got so much chaos and uncertainty in their life, and one way they stay sane is they measure things. They measure blood pressures and blood sugars and lipids, and that's one way to kind of, with all that chaos, to try to kind of keep your eye on the prize. And I thought, wait, we don't do that with depression. What do? The patient comes back and I said, how are you feeling? What if you had the blood pressure come back and you said, how do you think your blood pressure is? That would be wacky, right? And what the patient does is this. They smile at you and you're a nice doc and they're a nice patient. They say, I'm a little bit better. And you'd say, great, keep taking that med. That's really how we treat depression, most of us, even psychiatrists do. And if I treated blood pressure that way, here's what would happen. I would start everybody on 25 milligrams of hydrochlorothiazide or maybe a little bit of lisinopril, whatever. And I would have them come back and I'd say, how do you think you're doing now with your blood pressure? And they'd say, I think it's a little bit better. And I'd say, great, keep taking that 10 of lisinopril. And guess what? We'd have 25% of our hypertensives under control. As it is, we only have about 50% under control. But why is that? Because every time you walk into a doctor's office, somebody puts a thing on you and you can't get in without somebody measuring your blood pressure. And if the number is too high for too long, somebody's going to do something about it. And I said, we got to do the same thing. Depression isn't that hard. Every time we touch one of these patients, we're going to give them that PHQ-9. And if that number doesn't budge, somebody has to talk about it. It might never budge, but we can't just ignore it. The other thing we did is we said, look, when we first talked to these docs, they said, bring in a psychiatrist, have a psychiatrist see all our patients. We said, that may or may not work. That's hard to really make happen. But I said, we give every one of you a psychiatrist, but a little bit different. So every one of these practices had a psychiatrist assigned to it. And the job of that psychiatrist is they had to meet once a week on the telephone or in person with that care manager and go over every single patient in the caseload who was not improving in their depression scores. They didn't see most of those patients. They might say, okay, 10 of lisinopril, not good enough, go to 20. Or they might say the same thing for Prozac. They might say, give them some psychotherapy. They might say, maybe we're missing something here. Maybe it's not just straightforward depression. Occasionally they would say, this is the 3rd time I'm talking about this person. I don't really know what's going on. I should see them. So 10% of those patients, one of our psychiatrists saw in person. But every one of them got their cases reviewed and got consultations. And they would make these short notes to the PCP saying, try this, try that. That's kind of how the program worked. So what did we actually do? So our care managers did a lot of assessing and educating the patients. We did a lot of what we call behavioral activation. So the idea here is very short. Basically, we would say, the doctor put you on this pill. And that pill, will take a while to work, but what is it that you can do between now and next time to make you feel better? Something short, something really practical. And there's almost something that everybody can do. And the trick is when that person comes back the next time, you don't say, how are you doing today? He said, now you said you were going to do X. How did that go? And half the time the patient will say, oh yeah, I did it and went really well. And you say, great, what else do you think you can do? What's the next thing you can do? And half the time they would say, well, I didn't even do that. And then you really have to resist the temptation to sort of say, wow, yeah, you really are kind of a sad, pathetic person. You couldn't even tie your shoes. You couldn't even walk your dog. I don't know what we're going to do with you. And so we taught our care managers to just look at the patient and say, gee, that sounded like it was a bad plan. What do you think would work better? And one of our patients, when we finished the study, I called some of our patients to do some more, not data, but to get a qualitative sense of what they experienced. And here's what this man told me. He said, I went to the doctor's office. They had this lady there. I don't think she was a doctor, maybe she was a nurse. Anyway, he said, this lady, she was all over me like a cheap suit for a whole year. And it's kind of pretty much how he said it, and I was kind of taken aback, because I had written the treatment manual, and it says nothing on here about cheap suit. It says medications and problem-solving treatment. And I said, what do you mean? He said, well, you know, she did that thing where she said, what are you going to do between now and next time? And of course, I'm not doing anything. I'm drinking too much, and I'm depressed, and I'm pretty screwed up. And so after a while, I stopped going back to the doctor. This woman is kind of all over me. And so what does she do? She starts calling the house. What are you doing, Joe? He said, I'm not doing anything. So he says, she talks to the wife. What's he doing? I say to the wife, don't talk to that lady. And he said, and then communications broke down. And he said, 2 months later, he has a dental abscess. This was a man who was in Indianapolis who went to a county hospital for his care. And he's in the waiting room of the dental clinic at the county hospital. And guess who shows up in the waiting room? How are you doing? What are you doing to make yourself feel better? He said, you know, and I broke down and it changed my life. It was really interesting. What he basically said is, I went to this community health center and they said to me, you're in this thing now for 12 months and there is a way to get this depression better. And we're not going to give up until we figured out what it takes. And it might take changing your meds 4 or 5 times, but you're going to have to do something too. And it was a very interesting thing. It wasn't on our protocol, but it really taught me something about this idea of really going out after the patient. The other thing that I already mentioned is we do a lot of what we call measurement-based care. So we really said in mental health, we can measure, because if you're going after him, it's one thing to say, are you feeling better? Because eventually he'll start saying, yes, I'm feeling better, just leave me alone. But we said, are you sleeping? Are you eating? You know, you can measure this stuff. That's what the PHQ-9 does. I already told the story about the cheap suit. I think it's a very important thing. But why are we measuring? The reason we're measuring is because no matter how good your treatment is, the best med would only get 50% of the people better. And this is not different in diabetes or hypertension. Most people, we start on an antihypertensive, we got to change the dose 3 or 4 times. We got to maybe combine meds, and we have to do the same things with the psych meds, but we don't do it. 70% of the patients who came into the trial got started on a low dose of an SSRI, and a year later they were still taking the same SSRI, same dose, and not much better. So we said we need to be better at changing treatments. If they don't work, don't keep going with them, change them. And the only way you can do that is if you have that measurement thing. A little bit of data. So how well did this work? So remember, 1,800 patients, half of them got usual care, half of them got impact care, same clinics. So many of our primary care doctors had a handful of patients in impact and a handful of patients in usual care. The first thing we did is we said, how do you like your care? How many of you think your primary care and your depression care are excellent and very good? So this is baseline, perfectly matched. Half the patients said excellent or very good. And the health plans we work with said, this is fabulous. Look how happy our patients are. And I thought, this is terrible. These people are all depressed. They're getting crappy care, and they think it's excellent or very good. That's telling me that they don't know what good depression care looks like, right? So the same 50% continue to say excellent or very good in usual care. For those where we added the care management, it went up quite substantially. And we also, by the way, surveyed the 450 primary care providers, because remember, half their patients were getting the impact care and the other half were in the usual care. And 3 of them liked the usual care better. The other 447 of them said, this other thing is way better. So there were some people who didn't like it, very small number. Then we said, how well does this work? Okay, so we had 8 medical groups we work with. These 18 clinics belong to 8 medical groups. I'm showing you the 8 medical groups here. And then we said at the end of 12 months, how many of these people are really substantially improved in terms of their depression severity? And we used some research measures for depression severity to measure that. In our usual care group, if you plot a line through that, the average is 19%. So 1 in 5 of these people, remember they all had treatment, got better. For those who had the collaborative impact care, about 50%. So we more than doubled the likelihood that people got better. And we saw this in every single site we did it. There is some variation. This is our county hospital clinic in Indianapolis. Didn't look so hot here, but their usual care looked really bad because this was a inner city population, mostly African American, lots and lots of diabetes and other health problems. And you know, in that site, they almost quadrupled the likelihood that they got one of those patients better. There are a couple of Kaiser clinics in here. This is a Hayward Kaiser clinic. Number 7, this was an interesting clinic. So Kaiser has made a decision, here in the Bay Area and a couple of other Northern California sites years ago. They have behavioral health providers in every one of their primary care clinics. So this clinic came in. This is a huge primary care clinic, kind of like a primary care factory, huge. 40 PCPs practicing out of this place, bigger than many of our rural counties if you added all the doctors together. Anyway, so they came and they said they wanted to be in the study. And I said, you can't be in because I looked at your clinic. You already got what I want to do. You have a behavioral health person in every single primary care module, and they look like they're good people. And the medical director said, well, not so fast, he said. We don't do the measurement. We don't really collaborate. These people do their thing, I do my thing. These people never ask their patients about the meds. I want to be in, so we let them in. And you know what? You can't tell those guys in any way that I can figure out apart from the clinics who didn't have on-site behavioral health. So it taught me something about co-location. So co-locating a behavioral health provider, no matter how good they are, if you just do that, you're not going to make much of a difference. You really have to do collaboration, and that's not the same thing as, because otherwise what you get is you get parallel play. And it's not very effective, it turns out. And there were 200 patients that got, and those doctors in the usual care group, when we said you got randomized to usual care, they were very nice. They said to their patient, let me walk you down the hall and introduce you to our behavioral health person. So they all got on-site co-located behavioral health care. Okay, already told this story, so I called that one out. How well did that work for physical functioning? This is physical functioning, and what we saw in our usual care patient, gradual decline in physical functioning over the next 12 months. And for those who had better depression care, it actually went the other way. These are very significant differences, and we actually looked 24 months out. After we stopped the program after 12 months, people still had better physical functioning if they'd had better depression care. And we looked at healthcare costs. So for those of you who look about dollars, turned out that this was a very expensive group of patients to take care of. We have complete healthcare costs, either cost accounting data. So for Kaiser and Group Health and the VA, we have cost accounting data. So what it really cost them to deliver the care. And for the other sites, we have the cost that was paid by the health insurers. $31,000 on average. Over 4 years. These are $2,002, so this is probably today, this will probably be $40,000 or $45,000. Then we split them into the intervention and the usual care controls, and what we find is it costs $522 to provide for 1 year for the intervention patient, the care management, the psychiatric supervision, and then in every single other category of healthcare costs, you see reductions. You see reductions in outpatient mental health, in pharmacy, outpatient medical, inpatient medical, that's where we saw the really big reductions. And on average, we see a $3,000 savings that counts, that includes the cost of the program. So from an ROI perspective, you get about $6.50 back for every dollar you spend on this. So this was not only effective, it was pretty cost effective. So that made the Kaisers of the world very happy. Didn't make some of the clinics we worked with who were in a really serious fee-for-service mode happy, because the chief of orthopedics didn't like the fact that they didn't sell so many procedures, or some of the cardiologists. So it was interesting. We had mixed reactions depending on what your sort of setup was to this. We learned from this that you can, with a model like this, more than double the effectiveness of what we do now for depression. We also, I didn't show you the data, we have reductions in physical pain, we had better functioning, we had better patient and provider satisfaction, and we also looked at this. We had about 450 ethnic minorities in this study, mostly African American and Latino, and we actually had relatively greater improvements between usual care and the intervention in our minority patients than in our white patients, not because the care was so fabulous, but because the usual care is so bad. So the relative value of offering an intervention like this is actually greater for your more vulnerable patients. And it turned out it was pretty cost effective. So I'm a researcher, and we liked this idea. It worked really well, and we said, let's try it out with other populations. So this is a very, very quick summary. We've done, you can see here, 8 or 9 other randomized controlled trials now. We've tried this with diabetics with depression, both at an HMO up at Group Health in Seattle. This is county hospital data from LA County, USC, a very large study. Kathy L. did this with patients seen at LA County, USC who had diabetes and depression. This is a Todd Gilmer study. with a program that serves Spanish-only speaking diabetics where they trialed this. We have done it with depression in primary care. And there's a big study that a colleague of mine, Karina Davidson, published last year where they took people who have heart disease post-MI and they took half of them into this kind of a program and the other half they gave usual care. And this was in New York City, which was interesting because there's lots of psychiatrists in New York City. In fact, there are probably more psychiatrists in New York City than in most of the Pacific Northwest, I would guess. Probably more of them in Manhattan. So this was interesting. So every time we tried this, it worked better than usual care. So we don't feel like we need to do a lot more research to kind of convince ourselves. So the last couple of years we've said, okay, this is neat that it works in research, but how do we help move this, from research to practice? And I have to admit, I'm a little bit naive. When I got started with this, we started getting this stuff published in all these great medical journals. We had an article in JAMA and an article in the British Medical Journal. And an article in the New England Journal of Medicine, and we were so happy with ourselves, and we sort of thought maybe people will read that stuff and actually do it, but of course, that is like way, way academic naive. So we spent the last, almost the last 10 years sort of thinking about ways to help organizations take these ideas and put them in place. When I started with this, I went back to our funder, the Hartford Foundation. They had put almost $10 million into this big trial. This was a very large randomized controlled trial. And I said, I want to help people do this. People keep asking me they want to do it, but I need to have a little money to help them do this, just to help them, teach them how to do it. And they said, how much you need? And so right around that time, I was talking to a friend of mine. I was still in LA, and he's in the movie business. And he said, oh, that's interesting. So nobody's watching your movie, huh? You made a nice movie, he said, and now nobody's watching your movie. I said, yeah, it's sort of like that. And he said, well, how much you got lined up for distribution? And I said, what are you talking about? He said, well, I make movies, he said. I have to line up twice as much money for the distribution of the movie as it takes me to make the movie. Otherwise, nobody will let me make it. I thought, that's interesting. Makes sense in a way. So I went back to the funders and I said, hey, you gave me $10 million to do this really great study and I'd like to distribute it now. They said, how much you need? I said, well, it takes twice as much money. They thought I was they're like, whoa, we knew this guy was really weird. He's out there on the West Coast, he's a psychiatrist, he got into some bad stuff. So they gave us a $3 million grant. So it worked really well. And we went out and really have worked with 600 primary care clinics over the last 8 years. And we've taught about 5,000 providers in these 600 clinics how to do this collaborative care. And we have done this with a whole range of clinics. And we've learned some things from this. And here's some of the lessons I would say. I think the first one, this is my favorite quote, is a Japanese proverb. I believe this very much. These are complicated problems. I haven't met a single provider who has all it takes to do this. It really requires smart people working together really, really well. I don't think that co-location is sufficient. So for those of you who think all I need to do is bring a psychiatrist or a psychologist into my primary care clinic, they will do nice things there. They'll be very well liked, but they won't make a population level difference. If you hire a nice therapist and you think they will do something like our care managers did, it won't work terribly well either, because if they have a true sense of themselves as a good therapist, what they want to do is a whole bunch of 45-minute sessions behind a closed door with a fern and a nice lamp. And it's a beautiful thing. I'm not arguing with it at all, but it doesn't scale very well. It doesn't touch a lot of people. So it doesn't work so well. The other thing that I have learned in spades is whatever it is we try, doesn't matter what it is, psychotherapy, medications, it almost never is the thing that's going to get your patient better. That doesn't mean that you did a bad choice. It's like a lot of other stuff in healthcare. We often have to make changes, and we're very bad at making changes. We either drop the ball or we keep going forever and ever and ever. And that's true for psychotherapy as it is for medication. So we learned we really have to have systems in place that push people to make these changes. This is very complicated. I won't go into a lot of details, but one of the things I've learned is it's not good enough to put people through like a long training workshop. Because what we did when we first started this, we would run 2-3-day training workshops, and everybody would bring their people and we would train them how to do it, and then we had this fantasy they would go back to their organization and just make it happen. Of course, also a little bit naive. So now what we do when we work with an organization, we say, let's work together for a year or two and engage in a program where we work together, where we really help you build this. And the very, very beginning of that program is actually the kind of thing I'm doing here tonight. I introduce the concepts to a multidisciplinary audience, and I say, does this idea sound like something you want to do? The next step is we do what we call a team building effort, and I'll show you some slides on what that means. And that's basically saying, who do you already have? Who is doing what? What else is still needed? What kind of training does everybody need? And that's going to look very different in your clinic than it looks in the next guy's clinic because of the population you serve and so on. Then we do a training, and we'll train the whole team. We also have to train our psychiatric consultants, and that's what Anna is doing with me. We're going to do a training workshop for psychiatrists in San Francisco on Saturday, because psychiatrists are not taught to practice this way either. They're very uncomfortable with this. I don't see the patient. What do you mean? What are you talking about? How can I really do this? What about liability? And so, everybody has to stretch a little bit when you do this kind of an interdisciplinary program. And then what we do is we provide a fair amount of support once people launch. We listen to cases, we make sure things are really going well. And then the stuff down here is more to do really with QI, with measuring, because I'm not a huge stickler on fidelity. So you will meet some people on evidence-based practices that say, you have to do it exactly this way, my way, this is how I did it in the study. And that is kind of interesting, but it's very hard to make happen. So what I will say to you is, you don't have to fill out a fidelity scale, but you have to measure outcomes. Because at the end of the day, your patient either got better or they didn't. And if they didn't get better, we missed something. So then we have to both look and see, is there something we missed along the way? Is there something that's not working in your setting? And if you're going to do that, if you're committing to tracking the outcomes, I don't need you to be sort of really, really tied to some of the fidelity stuff. There are a couple of principles that I think are really, really important that I wouldn't let these are the sort of 5 principles that I think you have to kind of keep in mind if you want to do this well. The first one is this notion of patient-centered care. You really have to think about who all needs to be on the team to help the kind of patient population that we serve. And you have to have those people learn how to play well together. I make a joke sometimes about team care. I say, if you think about sports, everybody on a team knows what a goal looks like, right? Even though they all have very different roles. They all know what does it look like when somebody scores a goal. If you ask people on some of the teams we've consulted to, what does a goal look like? What does it look like if we're really successful? We get 5 different answers. Everybody has a different idea, including the patient. I like the patient on the team. I feel very strongly the patient should be on the team. But if 5 people have 5 different ideas of where the goal is, that's very difficult. The other thing that we have in healthcare is we don't train as teams. We train all the quarterbacks with other quarterbacks and all the wide receivers with other wide receivers. And the guys who are the punters, they only train with punters, right? And then we say, go play football. That's kind of how we train in healthcare, right? Doctors train with doctors, psychiatrists train with psychiatrists, and then we think they're going to all come out and play well together. And it really takes a lot of what we do when we train. We really sort of have to focus on how do you communicate well, how do you hand off well. That nurse care manager, how does he or she get in a doctor's face in a nice way and give them a really short communication about what is it I need from you right now? And a lot of the mental health providers we've put into these clinics, they come from a mental health culture, which is a very narrative culture. And they like stories. They go in and say, guess what? He told me yesterday, and this is really amazing. And they go into this long story, and the doctor says, what do you want me to do? Right? Primary care is I'm making caricatures here, so they're probably going to offend somebody, but it's really interesting. And, you have to learn that stuff. And we have to teach them, it's good that you have the whole story, but they don't need the whole story. They just need to, I think we need to change X, or our psychiatrist said maybe we should try X. If they need the backstory, they can ask you about it. So that's one thing, patient-centered care and really working well together. Population-based care. This is huge. I think it's really, really important that we commit to knowing who is in and who's out. What we do is, as clinicians, we treat what I call numerators. We don't keep track of the denominators. So somebody shows up in our clinic, and we do the best we can that day. They bounce out. If they don't come back, we don't know. But in impact, we were able to track all those patients, and even the patients who never came back, we had to count them. We didn't get credit for them. And if we didn't get them better, we weren't going to look very good. So we learned something about sometimes you can gain the most, not from the people who are using you a lot, but from making sure that those people who are not coming back, who've had 1 or 2 touches, actually have a couple more touches. So I'm a big believer in registries. Everybody who does some of our programs, I said, you've got to be able to know who is in the program. You have to have a way to track that. We already said a lot about this measuring and treating to target, making changes. Evidence-based care, so we saw a lot of variation. Some clinics were using, what looked to me reasonable trials of antidepressant medications. We still had a bunch of clinics and doctors who were doing things that are way out from where the evidence base is today. We saw a lot of benzos used, a lot of barbiturates used, and they're not bad drugs in a way, but they're not going to get somebody out of a major depressive episode. So there are still places where you say, and this is true in psychotherapy as well. There are lots of people in mental health that are doing things that are really well-meaning, but there's really not any evidence that that's ever been shown by anybody that it's going to get a client better. And then the last one is something I've added more recently, and this is the notion of pay for performance. I really think that if you can hold the delivery system accountable, not just for producing care, but for getting the right outcome, it makes a huge difference. And I'll show you a slide at the end in a program that we're doing. And it gets the right people to talk to each other. So when your administrator realizes all of a sudden the check that's coming to the clinic for your program is 25% less than what it was last year, they said, what happened? And if your clinicians say, well, we have these indicators now, we have these performance measures, and we're not meeting them, all of a sudden they start saying, what do you need? And we've had these really interesting discussions between administrators and clinicians about what does it actually take to get this job done. And I'll show you a slide at the end here where we can show that makes a huge difference. So this is more of a concept. This is actually a slide that Anna developed with me. So when we build these, what do you have to have? So there is a bunch of stuff above this line. This is all what's in a community health center, primary care clinic. There is a patient, the PCP. We add this care manager role. It's a very, very important role. And you have to have this consulting psychiatrist. This is a very small role, but a very important role. That person doesn't go fix all your patients, but they're accountable for reviewing every single person who's not getting better. That's part of their job. And they have to sort of think about, what do I have to offer here that might make them on a different track? They might talk to the PCP about this. Most of it, actually, they're doing this work through that care manager because this PCP is busy, not so easy to get a hold of. Occasionally, they will also deal directly with the patient. Now, some of our clinics, we have other behavioral health providers. We have CD counselors, we have, you might have a therapist, you might have a really good social worker. They all are important. They all add value. You just build a workflow where these people all work well together. But you can't get it all done in primary care, and we know this. And for some of our sicker patients, we need to reach out to substance abuse treatments. I'd love to have the substance abuse treatment in here. In fact, we're working towards that. But many of them, we still have to reach out. They might need voc rehab. They might need to go to a community mental health center. But when they go there, we don't want to just disconnect from them. They still have asthma. They still have diabetes. They still have other things for which they need good health care. And the job of this care manager is really to kind of keep track of this. I'm going to actually skip through a couple of these because I think I've already told most of this. Is just telling what does everybody do. So everybody has a game plan. Like when we have an orchestra, everybody has music and it all has to come together nicely. But I think I've told you most of this. I will say a little bit about the psychiatrist because it is very different from what we are trained to do. So your job is to regularly, weekly review these caseloads, and you're going to focus on the patients who are not getting better. And that's going to be a lot, maybe 50%. But on the other hand, actually, you're going to start seeing a lot of these patients actually do start getting better. It's really, really nice. You can do this. You can see the patient in person if you're in the clinic. We have some clinics where we have the psychiatrist practicing on site, and they might have a nice mix of doing these case reviews and actually seeing the patients. But again, focus on the ones that are sick. And we can do it in telemedicine. We are experimenting. We have very high-end telemedicine equipment, and we've been doing that because we're in the WWAMI region with clinics in Alaska and Wyoming for a long time. We're actually experimenting right now with using much lower tech stuff like Skype because that doesn't create so many barriers. And as a psychiatrist, I don't need to touch the patient. I already heard from a care manager usually 3 or 4 times about them. I have a pretty good idea of what might be going on, but I'm sort of saying, gee, is this person bipolar? Is there something else where I need a little bit higher level of skill, where I'd like to make my own judgment? I don't need to do a full-on eval, but if I had 20 minutes talking to that patient on Skype, I might have a pretty good idea of what might be going on. So we're trying a whole bunch of different ways to sort of make that psychiatrist useful. The other thing our psychiatrists do is they provide a fair amount of education for our primary care-based providers, and they do that not so much doing what I'm doing right now, which is talking at people, but last year in the program that I'll mention here towards the end, we have done 10,000 of these case reviews, and every time we do a review, we write a little note, very short little note that says, how about this? Try this, and if it doesn't make any sense, give me a call. And you know, we have seen a tremendous change in our colleagues in primary care, because by the 4th or 5th time you're saying, try this, you know, they're a step ahead of you, they figured that out. And it's a very nice way to learn because it's very case-based. It's not going to lectures. How do we build a team like this? I think it starts with figuring out who is our population, what do we need to do for them, and that's very, very important. And then we use a couple of worksheets. I'll just show them to you briefly. We do a staff self-assessment, we do a summary, and we do a little team building task. The most important part is at the get-go, we all need to define what a goal looks like. You know, what's the target? How would we all know this client get better? And then we have to say what needs to get done. There are some things that are pretty obvious. Somebody has got to find the patient. That could be a screening done at the front desk. That could be the PCP just saying this person doesn't look well. Lots of ways to get that done, and it varies across populations and across clinics. Somebody's got to call it something. Somebody's got to make a diagnosis. That's often a PCP. That could be a mental health provider, but you got to get clear on who does that. And it's not going to be the person at the front desk who hands out the screener. It's not going to be your MA. Somebody's got to get them engaged in treatment. Somebody's got to make sure that when something got started, there's follow-up. Somebody's got to do all of that communication tasks. If the patient needs a referral, who's going to do that? And who's going to follow up to see that the referral actually happened? 50% of the time when we refer somebody out from primary care, they don't ever even go. And half the time they go and they have 1 or 2 encounters and then they're back in our clinic. Who's going to do that? Those are the tasks. And what we do is we put all those tasks on a big sheet. These are the tasks. And we give that to every single person in the clinic, your front desk person, your PCP, your MA, your social worker in the clinic, and we say, fill this out. Look at the task and say, is this something that I think is a priority? Is this something that I do now? If I don't do this, is there somebody else in the clinic whose job it is to do this? Then, is that something that your organization is good at? Is it something I'd like to learn? And we do that independently, and we collect them all, and we go to do a next sheet. Same thing, all the tasks are there, and I take everyone's sheet and I put little check boxes. And it's really fascinating, because now I've gotten very granular. And what I see is there's a whole bunch of things. Everybody said this is really important, but nobody signed up for it. Or everybody wrote in someone else is doing it. And then I find things where, everybody says it's important, and everybody says I'm doing it. So, both of those aren't so great. And then I go to the third step and I say, okay, let's look at every one of those tasks. So this is the identify and engage patient. Who's going to find them? Who's going to screen them? Who's going to make the diagnosis? And who's going to get them engaged in treatment? And engaging in treatment in this program is often a PCP making a really, really compelling sell to their patient to work with this care manager and their behavioral health person. Because when that's not done well, it doesn't go very well. The patient gets the feeling this PCP is not comfortable with me, they think I'm a head case, they're sending me off to another person, even if it's in my clinic, and it doesn't go very well. But those are all the tasks. And then we say, who's going to do it, how are we going to do it, when are we going to do it, where are we going to do it, and what do we need to change in the practice to kind of get our way there, and who needs what kind of training. And if you go through it in that kind of a systematic way, what comes out for every clinic is a different looking thing at the end. But it captures those principles. And you got a good shot at having something, I think, that'll help you do something. I'm going to, at the very end here, go through one example of a program that we have started a couple years ago in our state. It's called the Mental Health Integration Program. I think it's a nice real-world example of taking these ideas well beyond research and making them happen in some very, very real-world community health centers. We were fortunate a couple years ago. In our state, they funded this program. And we also got funding I'm in Seattle, so King County is our county. That's our largest county in the state. The county said, look, we have a lot of patients that are uninsured. We have these safety net patients that are bouncing around. We have a lot of patients who are illegal, that can't get health care anywhere. They raised the tax levy to create these kinds of integrated services for those populations. The plan is administered by the Community Health Plan of Washington in partnership with us. We started this in 2008, and we now have this model of care in place in 110 community health centers and 30 mental health centers in our state. We serve a little over 20,000 clients. And this is kind of a very big picture view of what these clients have. So almost all of them have one or more chronic medical disorders. Most of them have at least one diagnosable mental disorder, and a good number of them have alcohol and substance abuse problems. And you can see there's huge overlaps. And this is, if there's ever a reason to say we should work together, we should do integrated care, this is it. I mean, there's just no way to kind of pull all these people apart and say everybody gets a crack at a different part of the problem. In King County, we also have high-risk moms. We have about 1,000 high-risk moms in this program and their kids. We serve uninsured adults, older adults, and we also serve vets and family members of vets. This has become a big thing for us. We're a big military place up there, and there's tons of family members of veterans who don't have access to good health care, even if their spouse has care at the VA. It's the same basic model with an extension, which is basically we have very formally linked in our community health centers. And we track everybody using a web-based care management tracking tool called CMTS. It has two functions. The first one is a registry function. And the notion here is everybody who's in this program, all 23,000 people, they're in our registry, and no matter where they go, if they hit somebody who is part of the program, they can see what's going on with that client. And the program will push at our care managers when a client looks like they're falling through the cracks. So a person who came in, got started on something, if they're not coming back in, if there's no note recorded, in 4 weeks, the care manager gets a thing saying, here is that person that's falling through the cracks. Here is his telephone number, and here is his mother's telephone number, and here's his brother's telephone number, because our care managers have learned at the very front end of this. They are now saying to our clients, I can guarantee you there's going to come a time when I need to get a hold of you and I can't, because your cell phone's been disconnected, or you've moved, or 30% of the folks in this program are at least intermittently homeless. And so they say, give me every single way you can think of that I could get a hold of you. And they write that all into our program, and that's what they do. They're that cheap suit, right? The other thing that this program does is it structures their work with the patient. So when they log a session with a patient, it's not a blank note. It actually says, last time you did these meds and you did this activity plan, follow up on it. Because it's very different from starting with a blank note where you're saying, how are you doing today? What should we talk about today? So things don't get lost. I'll show you a couple of quick screenshots. When I log on to this, one of the views I can generate is what we call a clinical dashboard. So it tells us who is this person, what are the diagnoses, what are the PHQ score, and this is a person who has anxiety, so we have an anxiety score. They have PTSD, we have a PTSD score. What's the summary? Are there any real safety concerns? So if they've had suicide attempts, what are the current meds? What are we working on? What are the activity goals? And the interesting thing with this is every one of these elements could actually theoretically come from a different person. So some of it might have been entered by the PCP. Some of them might have been entered by a consulting psychiatrist. Some of it could have been entered by the care manager. And every one of these, it says, who wrote this and when was it written? I blocked these out because this is a real client. And the idea is it forces that sharing, because right now what we do is we write, everybody has their own notes. And if you're in a mental health center, you write in your chart. And if you're in a primary care clinic, you write in your chart. And you never read anyone else's note anyway. You hardly ever read your own notes again. So the idea here is trying to create a shared view. We can also say what all has happened to this person. So these are the diagnoses we're treating, and this is every time we've had a contact. Was it a phone contact? Was it a clinic contact? What was the PHQ score? What were the meds? And then we graph the score down here. We can summarize it at a caseload level. So this is a real clinic. We have 2 care managers here. They're both LCSWs. One of them has 70 patients. One of them has 86 patients active right now. They're both in a big FQHC in Seattle. How many of them have had a clinical assessment? What's the average depression score? How many of them have had follow-up? 92%. This is really interesting because this is a clinic when we started working with them, 20 to 30% of those patients were having follow-up. And we said, you got to be this cheap suit. It's got to work. It can be done. They said, oh, our clients are homeless. It can't be done. And we said, well, let's try. There are guys down the street who are looking like they can do it. Let's see if we can do it. And guess what? These guys are not following 92% of their patients. On average, 10 contacts. And all the way over here, I can tell them in real time how many of your patients are actually better and how many are not. I can give the PCP a little printout. This is basically going to tell the PCP, what are we working on? What's the summary? What's happening to the depression, the anxiety scores? What are the activities they're working on? What are the meds? And if there's a psychiatrist note, it'll be a short little note. I don't have it on here. Very short little note that'd be at the bottom here. What are we serving? This is not just depression. So we're seeing patients that have depression, that have all kinds of anxiety disorders. We have a lot of patients with PTSD. 17%, the primary diagnosis is alcohol or substance abuse problems. And there's a big asterisk on this because I think the truth is it's probably closer to 30 or 40 or 50%, but we are not very good. That's yet a whole other silo. We're not very good in primary care. We are now more comfortable saying to a patient, I think you're depressed, than to saying, I think you have a serious alcohol problem, because I think it's even more stigmatized. And the docs, frankly, don't like telling people what they have if they don't feel like they can offer something. If they have depression, they feel I could pull out my prescription pad and give them a med. If I tell them they have an alcohol problem, what am I going to do? So I think we have a long way to go here to do better with this. 15% of these patients are bipolar. This was a really big surprise to us because we kind of thought that's where it's mental. So the bipolars are in the mental health centers. A lot of these patients in primary care either are diagnosed bipolar or they're coming in looking depressed, but if you take a good history, you find out some of them really are bipolar. And if you just put them on an antidepressant medication, you could put them in a really, not a full-on manic episode, but in kind of like a yucky mixed state. That's a pretty crummy place to be. And we have had to kind of re-diagnose a bunch of those patients as bipolar. 45% of them have thoughts of suicide when they come into the program. So these are not all worried well. These are pretty sick people. This is, I'm almost done here. This is a screenshot of one of our FQHCs in Seattle. They've been with us in this program for a couple years now. They have 6 clinics, about 2,000 clients. And here are the populations. These are a disability population. These are our uninsured clients. We have older adults in this program. We have vets and family members of vets, and we have our high-risk moms. They all have pretty high PHQ-9 scores when they come in. You see here about 15, 16. That's the average. So we have lots of people who are in the 20s as well. We are able to follow 80 to 90% of them. They have about 7 or 8 contacts on average. A little more than half of those patients have had their case reviewed and treatment recommendations made by a psychiatrist. And a good number of them are getting better. When we started this program, these numbers were in the 15 to 20% range, very similar to what we saw in our usual care study. And now, these are complicated patients. We're getting them better. A third of them, like I said, are homeless or living on someone's couch. Many of them have had other huge social challenges. The last thing I'll mention is this issue about pay for performance. So we started this program in 2008, and we were really excited about it. The health plan and the state put these care managers into a lot of clinics, 29 clinics to start. There's a lot of money got spent on this. We designated 4 FTE consulting psychiatrists to cover all of those clinics. We went about our work. And I looked at the numbers about a year in, and I wasn't overly happy. And I said, gee, there are some people who are doing a great job, and some people, it really doesn't look like they're following these clients very much. They're not getting a lot of them better. There was 4-fold variation across the clinics that we were working with in the likelihood that they got one of these patients better. So we said there's got to be a way to reduce this variation. And so we talked about it for a long time, and we said, look, let's see if we can hold those clinics accountable for some of this performance, because if it's a 4-fold variation, that means there's a room to improve. So in 2009, we instituted a pay-for-performance component to this program where 25% of the payment to the clinic depends on you meeting a couple of performance indicators. That's a big chunk of money. That's a lot more than has been used in a lot of other P4P programs that I know of. But we figured, hey, it's got to be enough to get on someone's radar screen. And the way it worked, they said, look, you got to give us money to do better. And we said, no, actually, we're going to take away 25%. So next year, you're only going to get 75%. And that is pretty much, in most of those clinics, that made the difference between them breaking even or making a little bit money with this program or them losing some money. And so it really did get some of the COOs and CFOs and CEOs' attention. The guy who runs the biggest FQHC in our city, we have 9 clinics, big clinics in Western Washington, called up and he was just livid. He said, we got into this and we're getting less this year than last year. We didn't even like it last year. What the heck's going on? And I said, well, you don't meet any of his indicators. And he started looking at them, and in the indicators were actually things you can't really argue with very well. I'll show you what the indicators were. No, actually, no, I can't show you what they were. They were 3 indicators to start. The first one was you got to touch at least half the people who are in your caseload every month, at least twice every month. And a touch was a phone call. So if you made 2 phone calls, you were good. You didn't have to see them in person. We said if you called up and you did a PHQ-9, that's a touch. Half the patients in your caseload. So that's, that's not too hard. We said you either get the patient better or you get a consultation. What's not good is that you just keep doing the same over and over and over. And then we had an indicator that had to do with medication reconciliation because these patients were going all over the place getting meds from lots of people. And we said the care managers need to once a month certify in our tool that they've sat down with the patient and said, what are all the meds you're taking right now and who's doing that? And it was a really interesting thing because we got into this guilt stuff and the care manager said, well, I'm a social worker and I can't talk about the meds, and unions got all anxious, and it was very exciting. But at the end of the day, we were sort of able to kind of get everybody to agree, actually maybe it's okay for them. They don't have to change the med, but everybody is empowered in this program to say, hey, I think it's not working. And it made a huge difference. Those were the 3 indicators, and if you got all 3, if you got one of them, you got 5%. If you got all 3, you got 25%. You were back to 100%. And so we did something interesting. This just got accepted. I submitted this for publication in the American Journal of Public Health. I just found out yesterday they accepted this paper. It will be published in the American Journal of Public Health. But what we did is there are 3,000 patients who went through this program in the same clinics before we put this P4P thing in. And what I'm showing you here is the amount of time it takes for the average, for persons to get their depression better. So at the end of the day, we get about 75% of these people's depression better. But it could take a long, long time. For half of the patients to get their depression better, it took 65 weeks. This is the same clinics with the same clinicians doing the same thing after the pay for performance. 3,000 patients in this line, 6,000 patients in this line. Look at that. We're still getting a little bit more patients better, but a huge change in how long it takes to get better. We cut that more than in half. And if you've ever had a serious depression, it makes a big difference if you have it for over a year or if you have it for 24 weeks. With our MOMS program, it went from 64 weeks to 16 weeks. And what's the difference? We're not sitting on patients who are not getting better very long. We're getting these consultations, we're changing things, we're going after them more, and it's closed this huge gap. And the variability between the clinics has gone way down. We learned a couple of other interesting things. So when we started this program, it was just in King and Pierce County, that's Seattle and Tacoma. The rest of the states, all the other counties didn't have it for the first year. And so we had an interesting opportunity to compare some other outcomes. So we said, what is the likelihood that somebody is homeless? These are the clinics that had access to the program. These are the clinics who didn't have access to the program in 2008. Now, when we saw this, we were really unhappy because what we saw is in King and Pierce County, this is where we had the program, we had more homeless people. But in the other counties, we had way more homeless people. So this was 2008. This is when the economy crumped. So we couldn't completely protect people from the effects, but we actually softened the blow, I think, quite a bit. We also looked at arrest rates. These are the folks in the counties that have access to the program. These are the folks in our comparison counties, and we pretty substantially reduced arrest rates in the people who were in counties that had access to these integrated care programs. So in summary, I think we learned that you can take some pretty complicated safety net patients, you can put these kinds of programs in place. You might have better clinical outcomes, but you might also end up with safer communities and less homelessness. And finally, I think this was the big lesson to me. You can actually, even in behavioral health, hold people accountable for getting good outcomes. And if they don't get it, I'm not a big believer in just shaming people or sort of harassing people. I would say we would all, though, want to see our clients get better. And if there is a clinic that knows how to do it 3 times better, maybe they have all the good patients, maybe I have all the bad patients, but maybe there's something else, and we should talk, and we should try to figure this out. And when you do that, you actually can make a really, really big change. We have a website if you'd like to learn a little bit more about this. We do a lot of training for this program. And I think in the end, I'm going to wrap up with these basic principles. Build something that's a team-based, patient-centered model, where the patient doesn't say anymore, don't you guys talk to each other, where the patient doesn't really say, when does the treatment start? You know, when somebody can explain to them, you know, you come to the right door, we're going to get you started. We may have to ask someone else to help us with this, you know, but we're not going to bounce you around. Make a denominator. Find some way of tracking who is in, because you might get more mileage out of helping those people who are not coming back than the ones who are always in your clinics. Measure. You use evidence-based care, and if you can, I think there is a lot of value in trying to make people commit to and being accountable for getting some outcomes. You know, I'm a researcher, so if you like references, I'm happy to give you some. You know, went a little over time, I apologize for that. It's a very quick tour. If there's anything that you saw, heard that sort of offended you, I apologize. It's very interdisciplinary. And there's almost always somebody who feels like, whoa, you know, this stretched me a little too much. If you have questions, I'm happy to take them on. I don't think I have a lot of the answers. I think I have a few of them because we've just tried this in so many ways with so many places. And we've had lots and lots of spectacular failures that I haven't shown you. And you learn from them too. Great, thank you very much for your time.